various speakers taking us through the basics of quality improvement and what it means, and even had a presentation where we saw even the initiatives that have been done in Kenyatta National Hospital in regards to quality improvement and the journey. And we really appreciate the speakers and the session that we had yesterday. And today we are continuing with the same, with still talking matters quality, commitment to continuous quality improvement. That's our theme, commitment to continuous quality improvement. And we are now going to begin our session. With us, we have Dr. Peter Nzumba. Dr. Peter Nzumba is a surgeon. Just a minute. Dr. Peter Nzumba, who is with us today, has done a lot of work in regards to safety and surgery. He's a general surgery he's a plastic and reconstructive surgeon who is based in AIC Kijabe. He's a consultant plastic reconstructive and hand surgeon at the AIC Kijabe Hospital. He has done a lot of trainings, starting off from the University of Nairobi, where he did his MBCHB and went on to do his master's in medicine in surgery. He then did additional trainings in plastic surgery at the Plastic and Reconstructive and Cosmetic Surgery Christian Medical College in India, and also trained in hand surgery in the same institution. He has been the principal investigator of the surgical site infection study in collaboration with World Health Organization and the University Hospitals of Geneva, with a grant from Velax Foundation, Switzerland. And he's the coordinator of the Surgical Unit Safety Program at AIC Kijabe, which is a collaborative project run by WHO in conjunction with Johns Hopkins University. He was appointed the clinical assistant professor, Department of Plastic and Reconstructive Surgery, Vanderbilt University Medical Center in 2012, and is also the clinical assistant professor, Department of Plastic Surgery, College of Medicine at Chattanooga University of Tennessee Health Center in USA. So we welcome you, Dr. Peter Nzumba, to give us your talk on the WHO standards of surgical site infection. I'll be the moderator for this session today. I'm Dr. Agnes Karingo from KNH Medical Research. Welcome all. For your question and comments, please post in the Q&A section. Welcome all. Dr. Peter Nzumba, karibu.
Thank you. I will be talking to us. Thank you for the introduction, and thank you for the invitation to take part in this meeting. It's a joy to be able to contribute. Patient safety has a special place in my heart. I was just going to add that I am a clinical epidemiologist, and so research is a big part of my life. I have a few, I guess, conflicts of interest. I not directly, but I work with a few organizations on surgical site infections, primarily prevention. The World Surgical Infection Society, Surgical Society of Kenya, and I am a clinical associate professor with Vanderbilt University Medical Centers informed. We have a startup research company that works to help residents for free get into research so they can write their theses or publications, etc. So I think I've mentioned that, but real quick, what are surgical site infections? And you can divide that into three: superficial, which are really a nuisance, but they're important because in our environment, they do take people from doing what they're supposed to be doing. The more important severe problem is deep incisional SSI and organ space SSIs. But these are easy to, the two most severe ones are easy to make a diagnosis of, because you either it's open or an ultrasound, CT scan, etc. will help with that. This, I'm not going to play this, but you will find this WHO's safe surgery video on the website, and I've got a little YouTube address there. So I'll quickly go into patient safety and culture, because that's the background to which SSI prevention belongs. And in patient safety, we do not blame the patient for complications resulting from an intervention by the healthcare system. In fact, the patient is the reason why we do what we do. And so that is one concept. Another important concept is that is the need for the development of a just culture. A blame culture finds fault in the individual, whereas a just culture establishes the source of the problem through a transparent root cause analysis. And most frequently, the system will be at fault. You may find that a person a person is at the end of the line. You identify this nurse, so-and-so gave this injection. But actually, when you follow through as to why nurse X, Y, and Z did that, is because the system is set to create that failure. And so the person who quote unquote made the mistake is not really to blame. Now, the just culture philosophy supports an environment where everyone feels safe, encouraged, and enabled to discuss quality and safety issues, where reporting and learning are key elements. When people don't feel safe, they don't feel encouraged, they will see mistakes, they will not report. In the OR, for example, I scrub, I touch something, I get contaminated. If we have a just culture in my OR, then the people I work with will tell me, Daktari, you have contaminated yourself, and so I need to go back and scrub again. Whereas where they know that there are problems with the culture, they will leave me alone and see problems develop over time. Reporting is conducted with within a psychologically safe environment, where there is demonstrated respect and support for the individual, and the potential for human and system fallibility is acknowledged. So anybody can be at fault. Everyone can trust those within the organization will demonstrate through their behaviors and decisions a fair and consistent approach to responding to issues raised. A just culture grows teams. Team members are accountable to each other and to the system, and that in general leads to the development and sustenance of a safety culture where we feel we're doing this as a team. Now, healthcare associated infections are important because patients coming into a hospital setup should not leave that hospital setup with a problem that they did not come in with. And yet 30% of our problems will be healthcare associated infections. Therefore, this patient came for a small problem, but will leave with a bigger problem that they acquire because of us. And so a number of publications, a big number from the WHO certainly, but also some that have been looked at by colleagues, Aiken and Karuri and Professor MacLeod did a systematic review on interventional studies for the prevention of SSIs quite some time ago. And we had this big study a few years ago in concert with WHO, as mentioned. Just looking at the number of publications in this country on SSIs, they're really limited, as are publications from around sub-Saharan Africa. When you come to the academic field, again, the number of publications are few. Now, unfortunately, these tend to stay at the university, which means they're not thrown out to the general public to read, which is a little unfortunate. So our encouragement would be for our master's thesis to get into publication, so that that data is not lost and left in publications within cupboards, but are accessible to help us with policy, etc. Now, quickly to the WHO SSI prevention guidelines, which were published in 2016. These guidelines are extremely important because for a long time, the SSI guidelines generally were published for specific regions. The UK, for example, have the NICE guidelines, NICE. The US has the CDC guidelines. Europe has the European guidelines, and Australia does have some, and you'll find them scattered here and there. But for the LMICs, low middle income countries, were left floating. So the WHO at the time came up with the most current evidence available. And as a team, we came up with a number of recommendations, of which 9 were strong recommendations, which means this. So the language tells you the level of strength. For example, an important one is surgical antibiotic prophylaxis administration should not be prolonged after completion of the operation. WHO SSI guidelines, the booklet is free, available online from the WHO website. Should be able to find that. Now, why is this statement important, for example, in our environment? Because the practice, if truth be told, is that antibiotic prophylaxis is often frequently continued beyond 1 day after surgery, with the thought of trying to prevent an SSI, so that the myth that antibiotics will prevent SSI, and the other sad myth is that the more powerful, the longer the period of administration, the better this will be. Now, unfortunately, the fact about surgical antimicrobial prophylaxis is that continuing SAP after an operation has no advantage compared with its immediate discontinuation. Instead, if you continue SAP, the prophylaxis beyond wound closure, you unnecessarily expose patients to risks associated with the antibiotic use, which will include costs both to the patient, the community, the hospital, the country. You expose the patient to allergies, and if a patient is allergic, then you can end up with anaphylaxis and mortality. Then you expose the patient to potential for acute kidney injury, multi-resistant bugs, infection with C. difficile. There is evidence from a systematic review that I will be sharing briefly, shortly, that avoiding postoperative continuation of surgical antimicrobial prophylaxis is associated with a reduced risk of C. difficile infection, for example. And indeed, the systematic review and meta-analysis is interpreted as thus, that overall, the authors identified no conclusive evidence for a benefit of postoperative continuation of antibiotic prophylaxis over its discontinuation, which in essence means that if you give prophylaxis within, just before the incision and not after wound closure, then that is equal to whether you give the same antibiotics for the next 1 week. Now, when you consider the advantages of stopping, because you avoid all the complications we just talked about, then we see why it is important to consider giving antimicrobial prophylaxis as prophylaxis. Anything else would be considered treatment by definition. Now, this is a paper that was published by one of our colleagues, some of our colleagues out here, and determinants of effectiveness of antimicrobial prophylaxis amongst neurotrauma patients. And you note in yellow, however, this was not statistically. So patients on prophylaxis were less likely to be infected than those who did not receive prophylaxis. Now, that is from simple figures, but when you look at statistical analysis, this was not statistically significant because a relative risk ratio, you salvaged what 13% of patients, and then when you look at your confidence intervals, 1, it's wide, 2, it involves null, which is 1. So really, in effect, no evidence for support in using, although the number of patients are few. What can we do? Consider an institutional antibiogram where you determine from all your cultures your sensitivity patterns. Of course, it is important to make sure that the cultures are appropriately collected. The most commonly used antibiotic is cefazolin. Now, unfortunately, a lot of us still use it for treatment, which makes it useless. If you use it in the OR as a prophylaxis, then using it in the ward as treatment beats the purpose. So if you decide you're going to use cefazolin, then use cefazolin as prophylaxis and nowhere else. Surgical antimicrobial prophylaxis is supposed to be specialty specific, based on the commonest organisms around wherever it is you're operating on. They should be narrow spectrum so that they're specifically aimed at specific bugs, bacteria that are found there. It should be cost effective, not expensive. It is important to note that guidelines are guidelines. They are not prescriptive. And even when you look at the WHO guidelines, for example, they guide you on what to do, but they do not prescribe you or for you on what to do at your local station. So even if we had Kenyan national guidelines, they will guide us as to what we should do, but they cannot tell you what to do at Kenyatta, me what to do at Kijabe, because our resistant patterns will be different. And I'll be sharing an old antibiogram, for example, from Kijabe. So the other things that we would consider include antimicrobial stewardship, under which you are concerned about AMR, and perhaps the most important, and I'm hopeful that somehow this group will discuss this and figure out what to do about this, is across-the-counter prescriptions. So I'm a plastic surgeon. I take care of wounds, exposed bones, exposed tendons, exposed this, that, and the other. And without exception, patients will come to me having had antibiotics which are completely unnecessary, but I have no antibiotic to treat them with at the point at which I would be taking them to the hospital, which means they're at the mercy of surgical debridement because no antibiotic is going to treat the bugs that they have. And of course, we in healthcare are to blame for cross-counter prescriptions. Our veterinary colleagues contribute some, but not as much as we do, unlike many other countries. Now, surgical antimicrobial prophylaxis, the choice is determined by wound class, patient allergies, institutional antibiogram, surgical specialty. And I think I've mentioned this, it is important to differentiate between SAP and treatment. The reason I've spent some time on this is because surgical antimicrobial prophylaxis consumes a huge part of the antibiotic prescription in institutions where you have guidelines. Where you don't, then it takes a very small bit and is not as important. but I think we can move to where evidence is taking us, which is for surgeons to use prophylaxis only in between, just before the incision and up to the end of the incision. And this is a French surgical antimicrobial prophylaxis guideline, for example, that, you know, you look at neurosurgery and what they consider. So cefazolin, allergy, vancomycin. So for almost everything, cefazolin serves, and many reasons for. You look at your ophthalmology, levofloxacin. So based on where you are, you use what the bags around that surgical or anatomic region will be sensitive to. You look at open heart, for example. Now, cardiac, there are a number of practices that deviate from the intraoperative, perioperative antimicrobial prophylaxis, but they are generally moving to where single dose or a repeat redose during surgery with nothing postoperative. So cardiac surgery, neurosurgery, and orthopedic surgery are the three culprits, let's call them, that tend to prolong their antibiotics. And the arguments which make, I guess, some sense is that it would be catastrophic, for example, for someone to have a total knee breakdown because of periprosthetic infection. Now, unfortunately, there is no evidence that giving antibiotics for a single dose intraoperatively is any different in preventing infection from one that continues for 4 days. So where you have no difference, then you use what makes a lot more sense, which is a single dose. And these are just orthopedics, trauma, and I talked about an antibiogram at Kijabe, and this is one. And you can look at, if you look at the last column, Pseudomonas, you'll note that you know, only 85% of Pseudomonas, which is this is some years ago, were sensitive to meropenem, and only 73 to piptazo, piperacillin tazobactam, which is scary because it means that almost 30 patients, at least 20% of patients, have no drug available to them. I mean, I guess colistin is still available, in this market, but it's extremely toxic and extremely expensive. So beyond meropenem, piptazo, there's nothing available to us currently, and nothing is going to be available, as we will see, for a very long time. SSI prevention. It is important to note that risk factors for SSI causation are multifactorial, and because it involves the interplay between patient factors, operation factors, institutional factors, and then the microbiological factors around the operation. And when we look at this, you've got institutional factors that include staffing, crowding, safety culture, etc. Then you have microbiological factors, patient-related factors, and operation factors, including surgical wound class, for example, the type of procedure, etc. Now, it is therefore reasonable that no single preventive measure will work, and WHO likes the term multimodal strategy. The US has used a lot of care bundles for, you know, if you think of VAP, a ventilator-associated pneumonia, for example, CAUTI, catheter-associated urinary tract infection. So you have care bundles for each of those problems. I'll just share this briefly. This study ended a few years ago. We've published the results. But we looked at 6. So our multimodal strategy involved patient bathing. So our patients bathed with antimicrobial soap. I have to confess that there is no scientific evidence that bathing with plain soap or with antimicrobial soap makes any difference. The important thing is to remove that. Avoid hair removal. That's an extremely important guideline there. And if you must remove hair, then you use clippers and nothing else. Then a good surgical hand preparation with either alcohol hand rub or soap and water. Most places are moving towards antimicrobial soap and water. And then appropriate antimicrobial prophylaxis, which is right antibiotic for the operation, right dose, right time, and appropriate discontinuation. You stop after the incision is closed. And then appropriate skin preparation. So for the patient, the gold standard is alcohol, chlorhexidine glutamate alcohol preparation. The iodine or iodophor alcohol preparation, these have been shown to be inferior to chlorhexidine alcohol. Then the 6th intervention that we put into this bundle was discipline in the OR, which means the number of door openings, et cetera, because door openings do interfere with the flow of air and the way microbes and skin squames with the bacteria that come from our skin, et cetera, behave. And so those were the factors that, the variables that we included in there. So that was just an example, but what we could afford and put in place. So strong recommendations include, I'll go through this and then I think stop so that we can allow for time perhaps for some questions if there are any. But so patients with nasal carriage of Staph aureus, and there are places where, for example, there's an island country where they had a 40% Staph aureus nasal carriage. And there is evidence that if you have Staph aureus in your nose before surgery, you're likely to end up with a Staph aureus SSI. And so, and for patients, say, undergoing open heart, you really don't want that problem. So patients undergoing certain procedures, or if you know that the population has a high prevalence of a certain bug, then intranasal applications of mupirocin 2% with or without chlorhexidine body wash before surgery. Then for general surgery, mechanical bowel preparation alone without administration of oral antibiotics should not be used. Now, I guess the important bit is that you know, the Americans practice mechanical bowel preparation. The Europeans practiced oral antimicrobial administration with mechanical bowel preparation. So for patients undergoing adult patients undergoing elective colorectal surgery, then you need both MBR, mechanical bowel preparation, and oral antibiotics. So we've already talked about no hair removal. We've talked about using surgical antimicrobial prophylaxis where indicated, because there are some procedures where prophylaxis is not indicated. And then it should be administered within 120 minutes before incision. The reason for the 2-hour period is because if you're going to use vancomycin, let's say you have MRSA proven in a patient, so you can't give them, you have to give them vancomycin, for example, and vancomycin needs to be given at least 120 minutes before surgical incision. Then surgical hand preparation should be performed either with suitable antimicrobial soap or alcohol-based hand rub before donning gloves. And then alcohol-based antiseptic solutions based on chlorhexidine for surgical site preparation. Then 80% fraction of inspired oxygen should be used intraoperatively, and if possible, for the next 2 to 6 hours postoperatively. I have to say there was quite a bit of discussion on that. Surgical antimicrobial prophylaxis administration should not be prolonged after completion of operation. Those were the 9 strong recommendations. The others are conditional, which means they do contribute, but the amount of support for them in literature is not that much, and I'll not spend time. These are available online, but they include, things like antimicrobial sealants. A lot of these are we buy because they are brought to us by vendors, and they have no scientific support. Adhesive drips and antimicrobial sealants are expensive, but you can see have really no place in for. They may make life a little easier, less contamination, etc. But there is no evidence to support their use for prevention of SSI. As wound protectors may be considered. Coated sutures may be used for the purpose of reducing SSIs independent of the type of surgery. There is no place for laminar flow ventilation. It's extremely expensive. Germany actually took it down. Unfortunately, in this country, we've constructed some ORs with laminar flow when there's no support. Actually, there is support for the fact that they are a cause of increased SSIs. So a lot of stuff that we spend a lot of money on have no support for the prevention of surgical site infection. Note that we're only talking about the prevention of SSIs. This is just effective hand preparation for surgical procedures in LMICs, and I talk about the same issues that we've talked about, but the conclusion is the fact that alcohol-based hand rubs are the most efficacious surgical hand preparation products available today. They are cost-effective and can be safely prepared locally in hospitals, even in LMICs. And we can certainly discuss how to locally produce them. And also, I guess the important thing that we need to figure out is how to standardize their production so that we use standardized products. So this is just a pictorial to help with, same as this, to help with the process of figuring out a culture of patient safety. SSI surveillance, teamwork, good communication, staff engagement, and then correct use of antibiotics. And correct preventive measures can reduce SSIs by 39%, which is what our study showed. Surveillance, SSI surveillance alone has been shown to cut down SSIs by up to 54%. So very cheap steps to take. There's some glaring differences between low and middle income countries and high income countries. We do not need to spend the same amount of money that they spend to prevent their SSIs. We can take simple steps to bring them down. Now, an important statement that perhaps I should make at this stage is the fact that all the data and all the guidelines we talk about are primarily for adults. What we do in children has no evidence. We just use what we've picked from adults. And I think we've discussed this, and I think I did make a note of the fact that we don't have any new antibiotics. I think we only have 2 new groups where they're trying to figure out something. There's some some information of using AI to discover new molecules. All the new antibiotics are mostly just taking antibiotics we already have and playing around with them, which means actually resistance is not far. I mean, there is resistance to colistin, actually described in Kenya a few years ago in colistin native patients. So I think I will stop there. You can see there's resistance of carbapenem, which is the next place after we develop MRSAs. These problems are with us, and so stopping the wasteful usage or inappropriate usage of antibiotics, I think, is important for our own survival. Thank you very much.
Thank you very much, Dr. Nzumba, for that very elaborate presentation and a lot of information there in regards to matters of surgical site infection. We really do appreciate that presentation, and it really lays a background and a basis for our next session. We are going now to go into the next step, where we are going to get some practical views and what has been happening on the ground in regards to some of the improvement projects. And to start us off, we'll have Mary Mushiri, who will be giving us one of the projects that they did in surgical site infection at Kenyatta National Hospital. Mary Mushiri is a degree holder in BSSN, peri-op specialist. Currently is doing her master thesis in medical and surgical nursing with over 15 years of clinical experience in KNH. She's the team leader, and she's going to now take us through one of the projects that they did here at Kenyatta National Hospital. For our participants, please feel free to give your comments and your questions at the Q&A. We are going to have a session at the end where we are going to discuss and have the Q&A answered. Thank you. Karibu, Mary.
Thank you very much. I'm going to present on a project, quality improvement project, on reduction of surgical site infection. And we were reducing surgical site infection from 9.51 that has been recorded to 7.5 among surgical patients done laparotomy at the Kenyatta National Hospital. Those are the team members. We did it as a team. Our mentor was Kimani, and down there our sponsors. Problem statement: laparotomies contribute to three quarters of all surgeries, developing surgical site infection in the general surgical wards. And out of them, the emergency operations that have been done, actually 68% of them contributed to the SSI. We know it is a leading cause of morbidity and mortality. It increases length of hospital stay and a lot of added expenditures that come with it. This project was aimed to assure a higher quality of healthcare to patients at a cost that is affordable by reducing the length of hospital stay and use of costly antibiotics and wound care products. It will also showcase evidence based on practices in reduction of SSI in resource-constrained settings. Our target was to increase the utilization of kevazoline, a surgical antimicrobial prophylaxis, from 14.5% to 90% by 31st October 2021. That is the added month. When we started off the project, we had our uptake at 15, but another audit was released by then, and the uptake of kevazoline was at 43%. So we needed to improve that from 43% to at least 90%. This is the root cause analysis. And when we did our root cause analysis, we found that there was a lack of information. People never knew that we had an antimicrobial steward committee that had come up with the Kevazoline as our drug of our drug of choice in surgical prophylaxis. Then we had our ordering system that was tedious, and our pharmacists, as in Kenyatta Hospital, usually work from morning to 5 p.m. So in the late hours, it was difficult to get access to the Kevazoline. There was a prolonged line in the administration of the drug, and the timing was also a problem. The heavy workload. So when we were doing our root cause analysis and our key drivers, we took the three major problems. And the one that was protruding most was that there was so much staff workload and waste of motions. That comes with our organogram that was there, that when a patient is admitted, we had the patient had go to the ward, the antibiotic is prescribed, the nurse has to go for the antibiotic from the pharmacy. Most of the time the pharmacy would be closed, so they had to walk all the way to casualty. And when they had a high workload, that meant that they would pick any available antibiotic for replacement in the day when the pharmacies were available. So lack of awareness, most of the staff never knew that we had a guideline, surgical antimicrobial prophylaxis guidelines, and the closure of pharmacy at night. So our key drivers, our key drivers was to utilize the staff to complete required tasks and to make all stakeholders be aware of the guidelines, and then to avail the Kevazoline in the, over the period of 24 hours. So interventions. What we did, intervention number one, was to conduct sensitization, and over there where you see the diagram, there are people learning. We had to do a lot of sensitization, go to the departments, the surgical department, the theater department, and at least conduct CMEs and training on the guideline. Then we had to shift the task of ordering antibiotic from ward nurse to the theater, another test in the theater. Then to mainstream the policy and to make sure that there were memos available for us to mainstream the availability of the Kevazoline. Now, what I mean when I say that the antibiotic was to be shifted to the theater is that we already had an available theater that was giving many other drugs minus the antibiotic. And you see the antibiotic was already there. So we were not utilizing it to the maximum. So these are the results of when we, after the interventions. You see at the beginning, we were at 43%. Then we maintained the graph and just lost a little bit. Then where you see the graph rise and then go down is when we started engaging the key, the prescribers. These are the registrars, the consultants, the anesthetists. When we engage them about the availability of the guidelines, the availability of the Kevazoline in the pharmacy and the drug, you see it has listened from 43% and now we are praying at 100%. Then all of a sudden, because it's a word that had gone down, that went down. But from there, we were able to maintain at 60%. So the same, and now by the edge of the project here, this is administration of Kevazoline for as surgical antimicrobial prophylaxis. You see this, the graph on is the percentage of patients receiving Kevazoline, and this was the number of patients that were operated in each day. And you see we have listened from there. This is the continuation of the subsequent days of the month. So it is continuation as we continued to enter data and carry out studies. So you see we have at the end, we were able to maintain at 100% up to the closure of the project. That is the end last month. So we moved from 43% uptake of Kevazoline as a surgical prophylactic antibiotic to 100% for all patients who are coming for laparotomies from the surgical wards. So at the end, you see the results. We were able to reduce wastage of the process. these were some of the achievements that we made as we were trying to increase the uptake of antibiotic. You see, our admission before then, a patient coming for elective surgery would be admitted, then the prescription of antibiotic would be done, the requisition of the antibiotic from the pharmacy, then the antibiotic would be taken to the theater, and then the theater staff get it and gives it to the pharmacist, who later would administer the antibiotic. Emergency admission, it was from casualty prescription. The antibiotic is taken from casualty pharmacy. It is brought to the theater. It is received by the theater receiving area nurse. It is given to the staff and then handed over to the anesthetist in the operating room and then given. And out of from what we improved from is that a decision now is being made to operate on the elective emergency patient. The patient is wheeled to the receiving area. The anesthetist orders the antibiotic with other anesthetic drugs. The antimicrobial is dispensed by the theater pharmacy, and the antibiotic is administered by the anesthetist. I'm sure it is just obvious that we were able to cut down the process. The impact of the outcome is that there is reduction of number of motions to pharmacy, and the staff, the nursing staffs, were freed to do other important duties, taking care of other patients, than moving from one area to the other looking for the antibiotic. Then there is the assessment on SSI that is still pending. We had we have talked about these figures we have talked about was before, but now what we are doing is after this intervention, at what rate are we? So we are doing that, and the rates will be out very soon. So to sustain this plan, because you have to look for a way to sustain this project, is that we want to be sensitizing all the new registrars on the surgical antimicrobial guidelines, and this is to be done by the Antimicrobial Stewardship Committee, and there should be an induction cost in the clinical area, and that will be reported to the Hospital Therapeutic Committee. Then there should be information and education and communication materials prominently displayed everywhere, that just at the look of things, you know that this is the drug that is recommended for all surgical patients, if need be. So this is to be done by the SSI Committee of the General Surgery, and then the display on the notice board, and this is to be reported to the HOD General Surgery. Key learning points when you are doing this clinical improvement is that healthcare systems are very complex, and however improvement is small, you cannot do it alone. You have to include others if improvement is expected. Defining the problem is the most important factor in any QI initiative. You must get the problem right, and then you can build on what you want to do. The next steps that we wish to do is to adapt the decision of algorithms of the surgical antimicrobial prophylaxis for ease of reference. It is to spread the sensitization across all the surgical departments, and that includes the obs-gyne, the pediatrics, everyone, and so that they also can adapt this. Then to embed QI teams, quality improvement teams and champions in all improvement initiatives. Then to utilize the A3 document. A3 document is just a borrowed way that was borrowed from the Toyota company on quality improvement. It's an A3 paper, an A3 document where you are able to enter all your proceedings, and it makes work easier and more objective. Thank you.
Thank you very much, Mary, for that interesting presentation and the project, and really good work for that project that you did in regards to the surgical surgical site infections and use of cefazolin in the surgical unit. This is a lot of good work, and you can see the practical aspect of applying the quality improvement science in doing a project and improving the use of this medication. We'll now go on to our next presenter. And here we have Faith Chicati. She is with us, yes, Faith Chicati, who is going to take us through a session of still on a quality improvement project that they did at the hospital at AIC Kijabe. She practices as a nurse in AIC Kijabe, and she'll introduce herself further and give us one of the projects that they did in their hospital. Karibu sana, Faith.
Thank you very much for this opportunity. Trying to share the documents. Screen. Okay. Sorry about that.
We can share it from our end. I think it was already shared. You can.
Yeah, okay, I got it. There we go. Can you see it now? Can you see my screen
Yes,
now? Oh.
Yes, we can.
Okay. Okay, my name is Faith. I work as a nurse anesthetist in AIC Kijabe Hospital. I'm grateful for this opportunity to present our experience with quality improvement in as far as patient orientation is concerned. The admission process has been quite a pain point for most of our patients. So we thought it would be great to address it and make our patient experiences a little more bearable. Ours was, wow, I think we may just have to share it from your end. Oh dear. Hello?
Hello, you can go ahead. Let's move to the next slide. Just
not moving, so
it's not moving from your end, huh?
Yeah. Let me try and open it up again.
No, we are the ones sharing. We have moved on to the next slide.
Oh.
Can you see it for you?
Oh, because I can't see it from my end. What can you see it right now? Sorry. Hello?
Hello. We can see the presentation is already up. You are not able to see it from your end.
No. Oh, yes. So the next slide, please. Let me just go with what you have. So our target was to evaluate the admission process critically, to introduce interventions and to improve patient experiences. Next slide, please. Ours was a team of 5 under the mentorship of Dr. Ima Baraza. So our hospital, AIC Kijabe Hospital, was generous enough to sponsor us for a course with Stanford University. And we're very grateful for that. Our target, if we can go to the next slide, was to reduce our admission-related complaints by 50%. That is from 16% to around 10%, and optimistically around 8%. And if you go to the next slide, I'll explain how we came to that. Next slide, please. We sent an SMS link to 1,000 patients who had recently been discharged from the hospital. That is between the month of April and June, inquiring about their admission process. From these 1,000, only about 200 responded. And from these, 16% had complaints concerning admission. So that is how we came from the baseline of we would like to move from 16 to around 10%. Next slide, please. So once we realized that, we sat down and did a root cause analysis. And as you can see from the fishbone displayed on your screens, there were several issues around our admission process. There were issues to do with personnel, communication, our billing process, infrastructure. So once we saw this, we went ahead to do a Pareto analysis to find out what was the major problem that we could address given the time frame that we had. So the major thing was our patients thought that the time it took from the decision to admit to when they actually get to the ward was too long. We actually took it upon ourselves to take a journey with a patient, and we walked with a patient from the gate to admission. And we actually discovered that it can take as long as 7 hours for a patient to be admitted, which can be pretty tedious for a patient. The other thing we saw was that they also thought that they also felt that there was not enough manpower and that the admission requirements were not communicated, so they kept going back and forth. Next slide. Next. So given the time frame that we had, given the time frame that we had, we chose to focus mainly on communication. So our key drivers were to reduce admission delays, to improve communication, and to integrate services where possible. So with this, we had about 8 interventions that we set up. The ones that have a red cross at the end are interventions that we attempted and abandoned at a very early stage of the project. That is, we couldn't be able to adopt a shift system or decentralize staff. The intervention of additional directional signage is on a temporary hold for now, since our management intends to construct a modern OPD complex. So we have put a pin on that and are still going to collaborate with management in future so that we make sure that our signage is something that the patients can adequately follow. So the interventions that worked for us were we were able to make sure that delays were communicated to patients. We were able to implement patient protocols. We were able to brand our patient attendants and customer care attendants with bright orange vests so that they are adequately seen by the patients. And we're also able to develop a patient admission brochure with all the requirements that a patient would probably have to meet before they're admitted, mostly targeted at elective patients. Next. So this is a track of our improvement process. It's a P chart. So as you can see, there's a red line and a green one. The red line was our baseline, which was 16%. We were targeting to get to 10%. So at the initial stage of the project, as you can see, our complaints ranged between the 16% that we had in our baseline. With continuous surveys, we also noticed the complaints would get up to about 40%. So our very first intervention was to sensitize our staff on admission protocols, which was done by our Director of Clinical Services. So that not only, at the end of the day, the burden of knowing the admission process would not just be for a select few, but for many more, so that we can have less complaints around that. So it seemed like there were less complaints for a while. Then we intervened by giving the branding our customer care attendants and our patient attendants with the bright vest so that they can be visibly seen by the patients. And against our expectations, the complaints actually went up to as much as 80%. But we soldiered on and introduced a patient admission brochure. So the complaints seemed to reduce for a while, but we never really got to our target of 10%. Next. Yeah, so after creating a clear platform, it seemed that the number of complaints rose beyond 40% on average against what we expected, but we took it positively because management can use this to inform decisions. Next. Since quality improvement is a continuous process, we still seek to sustain the interventions that we succeeded with. So the customer care attendants and the patient attendants are going to be the stewards of the bright orange vests. They're going to make sure that everybody is branded, in addition to making sure that any delays or inconveniences of some sort are communicated to patients on time. and they're going to continue reporting to the outpatient department manager. We are also going to endeavor to have 3 monthly staff refreshers on the admission process, mostly during our Friday audits. And this is going to be under the stewardship of our OPD manager, who will report to the chief nursing officer. Our admission briefing document, the brochure that we mentioned, is actually in circulation now. And we're going to let that remain under the stewardship of our credit manager, who will report to the OPD manager. So while we couldn't add signages per se, we are going to be doing impromptu audits of patients to assess the effectiveness of what we have on the ground as per now. And this will be under the stewardship of the OPD manager, who will report to the chief nursing officer. So the major lessons we learned at the end of the day is that you need to keep on trying, do not give up. So early on, we discovered that our SMART goal was not very specific. It was not SMART enough. And in addition to that, we kept on changing measurements. So at first, we sent the link to 1,000, the SMS link to 1,000. We attempted that a second time, nobody responded. We kept on trying. So we went for the interviews ourselves. We went to patients in the wards who are newly admitted ourselves and did some surveys, measured that, tracked that. Then at some point, we recruited the customer care attendants to also be gathering data for us. So we kept changing measurements. Then as far as the interventions is concerned, it would not be very productive to try too expensive interventions. But the good thing is that we learned fast and stopped early. That would be the decentralization of staff and the adopting of the shift system. So, but we realized that early on, there's a mantra that we were taught by the Stanford team. With quality improvement, you need to fail small, fail early, fail cheap, and fail forward. The other thing would be that the staff with the bright orange vest was both a measurement and an intervention. So an intervention in that patients could come directly to them and report any complaints. So they would know how many patients they have probably in the OPD, and then they would record whatever complaints they are given. It was also a measurement in that sense that they were the ones who are gathering the data and giving it back to us. So our next step is to extend this study to our discharge process, given all the lessons that we have learned. There's actually a pilot for the discharge process. We're going to take one of the interventions for admission, the one for decentralizing staff, and try and apply it to the discharge process. That's in the pilot phase, and we are very optimistic about it. Yes, thank you very much. Thank you.
Thank you very much for that, Faith, for that presentation, and even giving us some insights in some of the work that you've done to improve the quality and this aspect of admission in your hospital. And we really do appreciate your presentation. We are now going, because of time, we're going to move on to our next presentation. Dr. Wayego Karibu, she's a neonatologist working here at Kenyatta National Hospital, and she's been leading a number of quality improvement projects at Kenyatta National Hospital, and she's going to take us through some of the projects that they've been able to do. Dr. Wayego Karibu, and you can introduce yourself further.
Good afternoon to all of you. My name is Mary Wayego. I'm a neonatologist at the newborn unit, Kenyatta National Hospital. And what I'm going to share is something that came about from a meeting that was held within the unit. And from the participants that were in the meeting, the feeling was, there was a feeling of, feeling helpless, sort of, because we were going around looking at an outbreak that had happened within the newborn unit, and we're looking at solutions that needed to be put in place. And the solutions that were mentioned looked beyond most of us because they involved engaging with the hospital architecture, breaking down walls and creating isolation room. So within that meeting, we thought about what can we do as a unit and within what is within our reach. So we constituted a group that has different people that are team players and came up with some of what I'm going to share. And it's just going to be a journey. I'm not going to present any data. It is just going to be sharing of the things that we are doing as a unit, things that are within our reach. So what motivated this? We thought about what is ailing the newborn unit, what can we do within our available resources and expertise, what are the priorities, and what are we going to do about those priorities? So the first thing that we did is come up with a team that was going to take on this. And as we thought about who to include in the team, we thought about individuals that show motivation. We needed to include the different disciplines. You realize that care of the newborn is multidisciplinary. We needed to think about people that have demonstrated leadership skills, people who are ready to motivate people to improve things. We also needed to look at individuals that are available. Some of us might, have other priorities. For example, there are people who are in school, there are people who are doing other things. And we also needed people who are willing to be part of the team. And that meant being willing to do the extra things that needed to be done. So the team that we constituted had consultants. So it had the neonatologists working within the units. We also engaged with the residents, and in every meeting that we held, or in every season, we had to have the resident team leader for that particular rotation. We had nursing staff. Let me use the present because it's still ongoing. We had co-opted members that were going to assist us with technical issues. For example, the IPC department, the department that deals with public health, as well as quality department. So we engaged quite a bit with some of the quality department members. So what did we aim to do? We agreed that we're going to be having a monthly virtual meetings, and in these meetings we're going to discuss the priorities. We're going to discuss objectives of every of the strategies that we're going to take up, and we're also going to discuss and give each other tasks and make sure that everyone follows through and they report on those tasks in the coming meetings. We were also going to be looking at what is not working and what is not working as we met. And quite a bit of what we tried initially didn't work, and we had to rethink strategies, but it helped that we met every month to have a review of this. So we defined this as the priorities. At that point, what was big was the outbreak, because we had a lot of babies testing, having their cultures test positive for Klebsiella. Klebsiella was the biggest bug at that point. So we thought infection prevention and control was a priority. We also thought about communication and engagement in form of team, the different players within the newborn units. And the next priority we thought about is the preterm care bundles, because our biggest and our largest admissions come from the preterm deliveries. And we also have them being the biggest contributors of our mortalities. So we thought we are going to prioritize them and have come up with a care bundles. And also we thought about making our morbidity mortality meeting more engaging and more results oriented. So all these things are ongoing work. I'm just going to talk about one, and the rest probably, we will be sharing in the coming meeting. So when we thought about infection prevention and control, there were two things that we looked at, and the thing that we looked at was our hand hygiene compliance, as well as the culture positivity rates. At that point, the numbers were actually disturbingly very high, and we're dealing with an outbreak. Our hand hygiene compliance was also very poor. People, we needed to remind ourselves about when to wash our hands, the hand washing moments, the processes of hand hygiene, and we actually did that in all the meetings that were held between the teams. So what we'll do is, usually there is meetings that happen on every Monday and every Friday within the unit. And those meetings report on what's been going on from the Friday to the weekend. That's what happens on Monday. And during the week, that's what's reported on Friday. So during those meetings, we'd have those hand hygiene washing moments, a demonstration of the processes, and just generally appointing in every room and within the unit of people who are going to be handling matters hand hygiene. So that compliance is improved. Around ensuring this happened, we set targets. Again, I said I'm not going to present data, I'm just going to present the story. So we set targets on where do we want our hand hygiene compliance rate to be at. And we did a baseline and found it where it was and targeted to improve on that. So we'd have an incognito person just walk around and look at what people are doing, have that reported on Fridays, and come up with new strategies, see what is not working, what is working, improve on what is working. Do that every Friday and document those compliance rates, as well as get reports from the microbiology on our culture positivity rates. So what we try to do around, we mapped the newborn unit and looked at the various areas. So we looked at the entrance, we looked at the general work area within the unit and in each of the individual rooms. And we try to figure out what could be going on that is causing this very high culture positive sepsis. So at the entrance, we realized that there was, it was free for all. Anyone could get in without questioning. We had people coming all the way from level 3 to come and use the washrooms or to come and heat their food in the microwave. So we needed to figure out how do we control this. And what we did is we engaged with the security and had people, write down where they are coming, what the reason they're coming for, and if they're not newborn unit staff, what do they want, and would they involve the team leader to handle this. This is still work in progress because we still need to figure out how to come up with identifiers so that we only have the newborn unit staff coming in and only those that have a reason to come into the unit actually do get in. We also, it's still work in progress because again, at the entrance, we need to have hand wash basin and so that by the time someone is coming in, they've already washed their hands. So what we have been able to do is at least place a sanitizer, have all the moms coming in sanitized and everyone else who's coming in. it has seasons because sometimes you have security personnel changing. So some will be very strict, some won't be very strict. So it's still work in progress on how to improve this. Within the common areas, we also realized that we needed to educate the mothers in simple, very clear messages on what it means to have their hands washed before handling their babies. So we came up with very, simple messages like, so for example, mentioning your baby can get sick from just being touched with hands that have not been cleaned. Your baby can get infection and stay longer and even die from getting infection from unwashed hands. We also involved and engaged with the nursing staff who are in each of the units so that they do the policing and, remind people, do peer reminders and have the residents, the consultants, and everyone else handling the babies clean their hands before handling. We also came up with a plan of trying to decongest. So prompt diagnoses, early discharge were indicated. Again, this is still work in progress because we are hoping that we can get to a space where we'll decongest in a way that babies that have been stabilized can actually be down referred to the sites where they came from once they're fine. Again, we worked very closely with microbiology because they are the people that tell us what bags we are dealing with. So starting, we had a training on demonstration of how to do proper specimen collection techniques. And this is still ongoing because we still have to, come up with ways of ensuring that you have the right linen, the right cannulas for us to be able to do this. We also had to come up with a way of monitoring the pigeonhole so that samples taken are promptly collected and taken to the lab so that we also get timely results. We also had a way of communicating results so that when something positive is flagged, or we get an early phone call before the results actually do get into the unit, so that we can change antibiotics appropriately and also so that we can do isolation and cohorting of the confirmed cases. And then the other thing that we have insisted on, we are still insisting on, is doing septic screening, including cultures for all suspected babies to have sepsis and at admission of every baby. So again, the other thing that we realized was a problem is because in each of the rooms, we have different babies in different rooms. So for example, we have babies in the NICU, we have babies in the admission room, we have babies in the preterm room. So what you'd find is that people moved across the rooms to find, supplies in the different places. And in the process of doing that, transferring bags between rooms, and that was a problem. So we encouraged, and we still are encouraging, that every room is stocked with the supplies that it needs, and that is checked by the team that is leading that room for the shifts, and particularly for the day. We're also encouraging use of procedure trays so that when someone is doing a procedure on a baby, they collect all the needed things and they put it in the tray and do the blood works from that tray without having to move across and in the process contaminate themselves and contaminate the babies. We are still advocating for availing of sanitizers by every bed, at least in NICU that happens. In the other rooms, because of congestion, sometimes we find that we have one sanitizer for every 2 beds. Again, this is still work in progress because sometimes we have to fight to get these large quantities of sanitizer. Sometimes the people supplying this may not
completely understand why we would be asking for such large stocks. The other thing we've done around congestion is limiting the students' population. We realize we still have to allow them, but what we've done is for the medical students, we've encouraged that they learn in shifts. So there are those that come in during the morning, and there are those that come in during the afternoon, and then they interchange because they want to have interaction with the residents and with the consultants. So they shift themselves around so that they have these interactions. We've also been working with very closely with the nursing standards so that we can have a plan around how nursing students come into the unit. Again, this is work in progress. We've been trying to write to the various nursing schools so that they can avail to us their master plan so that we know who to expect when, and it can be planned accordingly. So those are some of the things that we've done within the rooms. The other thing that we have put in place is for every staff coming to work within the unit, just so that we emphasize how important it is to have our hand hygiene and IPC measures in place. We have insisted that everyone has to go through the WHO IPC course. It's an online free course. So students coming in, and it's part of the appraisals for the staff, they have to present that certificate. Why this is because it lays emphasis on the importance of us knowing the principles of IPC, as well as just showing how important it is. But as we do that, people also get to acquire information and knowledge around the IPCs that we are trying, the IPC measures that we are trying to institute. Student reorganization, I've talked about that, and we've also done quite a bit of room reorganization so that we have babies isolated according to their conditions. And we also have a way that we've organized so that we have care that can be planned around a particular group of newborn, of babies, because we have a variety of those. So again, we've seen with these measures that are really within our hands, within our reach, we've been able to reduce our culture positivity rates. And this is despite having more cultures being taken, because we are insisting on cultures during every admission. And when we think about changing antibiotic courses, we've also had improvement on our hand hygiene compliance rates. And there's more awareness on individual roles in all these measures. So people are more aware that they need to be very keen about IPC within what they can, within the resources that is within their reach. So we still have work in progress. We are still working around availing paper towels, availing bins that have pedals, that, so that people don't ask us questions about washing hands and having to air dry and take a lot of time. We are still working around how to have our courts cleaned every so often. So we are still trying to find the right staffing for that. We are still working around having staff identifiers for crowd control. And we are still working around getting a bigger isolation room, because the one that we currently have is very limited. So that's just one of the things that we have tried to work with. And we realize that IPC is something that needs to be ongoing. So even if we were to take on any other project, we still have to sustain the measures that we've taken for infection prevention control. So within the unit, we have people grouped according to the objectives they want to achieve per season. So there is an IPC group that now takes on this, and continues with what we've started and improve on the things that did not work and comes up with new things that, you know, they feel can work. But over and above this, there are other things that we are trying to come up with a plan on how we are going to handle. We want to have, you know, more, already we have a standardized neonatal admission record, but we also want to standardize other forms, and we've done that. We just need to have a way of ensuring compliance and improving on documentation. We've, you know, preterm care bundles is the next thing that we are doing, and we already have started working with the OBS-GYN team on training on the initial stabilization of the newborn using the current techniques, training on newborn resuscitation, having those refreshers every so often. So that has already started and it's ongoing, involving resuscitation, stabilization, thermoregulation, and early surfactant administration and early CPAP initiation. The next thing that we also are going big on is communication, because we realize that it's a big issue within the unit. On the one side, a group of, you know, say the residents communicate this or document this and do not communicate. So there might be broken telephones along the way. So we are also going to go big on team building and communication improvements. And that involves, you know, how do we do handover ward rounds at our different levels of the team players? How do we ensure that we have timely consultations as a way of improving in communication? And how are we going to enhance teamwork going forward? So those are just some of the little things that we are trying to do and improve on, and hoping to get, you know, bigger results. Our overall goal is to halve our mortality rates. So all these things that we are trying to do are around getting to that big goal of reducing our mortality rates to a level that it's a single digit. So I will stop there and allow for question, but also thank, because this is not a one-person thing. It's a group of us who have taken on this and working very well together as a team. So thank you very much for the invitation, and I will hand it over back to Dr. Ari.
Thank you very much, Dr. Oyego, for that presentation and for those initiatives that you and your team are carrying out in the newborn unit. It really is some good work going on. And yes, we do have to combine effort to have mortality rates going down, the newborn mortality rates, and we really appreciate the work that has gone in. We'd now like to welcome Prof. Mary Adam, who is with us, to also give us a comment on to comment on just the general presentations that we've had. She's done a lot of work in pediatrics. She's based in AIC Kijabe, a lot of research work and community health work, and it's really a pleasure to have her with us this afternoon. Prof, you can come in.
Thank you so much. It's a delight to be with you all. And I'd like to point out some of the things that the different presenters have been focusing on. And they're all about ways to move a quality improvement agenda forward. One of the features that was a big issue in my own quality improvement work was described by Faith when she pointed out how important it is to be willing to try things, actually measure them, fail, stand up again, and try again. And I think as we all are working on our own quality improvement journeys, the value that comes from tracking a consistent metric, so that you know if changes that you make are actually resulting in an improvement was well demonstrated across the different presentations today. And if I were going to leave you with one secret to success in your own quality improvement journey, it's that. Measure, track, and see if the changes you're making actually result in an improvement. So thanks for letting me share. Are there any other questions from the audience?
Thanks, Prof, for that. Actually, there's some questions which have been posted in the Q&A, and maybe one that you can respond to is this combination of questions in regards to the guidelines and the use of antibiotics in surgery, and when you're going to theater, maybe just a mention on that.
You know what? That specific technical expertise is a bit outside my own. And so I would rather defer that to those where it's actually in their high level of expertise. The people that talked about surgical site infection, Agneta has some specific things that she talked about with cefazolin, and she might want to respond to some of those.
Yes, sure. Also of that, I think, yeah, we'll do get to that, but I think that's it for now. In terms of your questions, we will now. Yes, go ahead, Prof.
No, I'm. Please go ahead with the other questions and the next agenda.
Thank you. So thank you, participants, for staying with us. We're now going to have some go through some of the questions that have been raised here. And maybe we'll start off with Mary. Mary, maybe you can take us through. There's a question here that is asking in regards to what are some of the challenges that you had as a team when you were doing your projects.
So thank you very much for that question. It is true we had some challenges, and some of them were this team player, because it was not a one person's project, is that the team players were from different departments. Getting us to meet and decide together was quite a big challenge. Actually, we would meet at the odd hours, early wee hours of the morning, and that was quite a big challenge. The other thing was on the CMEs and trainings, getting the team preparing and engaging other people, because in this quality improvement, you have to engage the key decision makers, the policy makers. It didn't go very easy for us. It was quite a challenge, but at last we managed. So those are just a few of the many challenges. I would also wish maybe to respond on a question on why cefazolin? Why did we arrive at cefazolin? If you allow me. This decision was informed by our antimicrobial steward committee. We have an antimicrobial steward committee in Kenyatta, and they're the ones who go around in doing studies and audits. So this was area had been informed, and the lessons that they had is that it covers a wide range of organisms. It is very specific. It is affordable in our settings. So going by it and the recommendation, that is why ours was just to improve on the uptake of their informed decision.
Thanks for that. Thank you, Mary. That was a very elaborate answer. A question here from Shemki Nara, great presentation on the part of past sample collection for culture. What can be done to prevent contamination? Maybe Dr. Wayego, you can help us in that, in the absence of Dr. Anthumba, just a bit on how to prevent infection when you're doing this sample collections.
Yeah, so it just involves doing a culture aseptically, the same way you scrub and when you're doing an aseptic sterile, actually a sterile procedure, because it involves cleaning the culture, the area where you want to take the culture from, allowing for drying, using the right solution to clean. Usually want to use at least 70% alcohol, allowing the site to dry. Depending on whether it's an adult or a child. So for the newborn, usually we open the cannula and get a vein and draw blood and put it into the newly opened culture bottle. Again, ensuring that the needle does not touch or does not get any contamination. The area that is cleaned is actually cleaned and dripped. Yeah, cleaned and dripped. And then getting the right volume, of blood so that you don't end up getting false negatives. So there are videos actually available. You can look up videos on YouTube on how to do proper blood culture collection. There are very many adult videos. What is not too much is the pediatric and newborn ones, but you can actually get quite a bit of that information when you look it up.
Thanks for that. Yeah, thanks for that response. And maybe just as a follow-up, there's also, I'm seeing one more question here that for you. So someone, Bernard is asking for hand drying. Thank you for neonatology team at KNH. So for hand drying, after hand washing, is it better to use the paper towels and not the hand dryer? Are the papers safer? Is that, maybe you can give us a comment in regards to the hand hygiene.
So dryers are actually not encouraged within the unit. The fan dryers. So paper towels that are discarded, paper towel, not cloth towel. Paper towel is what we use. Paper towels that are discarded, and if in the absence of paper towel, that's why we really would wish to have them. You would need to do air drying. So you hold your hands up until they get completely dry, and that can take some time. So to answer the question, because of the risks of trapping of microbes within the fan dryers and releasing them as you place your hands under them, that is a risk that you run by using the air hand dryers, as opposed to using the cleaned, paper towels or air drying. Back to you, Dr. Karingo.
Thank you for that. Maybe Faith Chicati, you can come in, and there's a question here on, for the Kijabe improvement study, would a project to reduce the admission time be useful?
To the best of my knowledge, there's actually a project ongoing concerning that. They're specifically addressing the admission time. So it's already underway.
Thank you for that. Yeah, it will be important to look at that actually in all our service area to reduce our admission times and our service delivery times. Yeah. We'd now like to do our final comments. Let me see if there are people who have raised their hands. Maybe Kemei, Zaharia Seta, Penina Mutua, Philomena Mutuka. I'm seeing that you've raised your hand. We'll see how best we can unmute you and have you ask your questions. In the meantime, as that is being done, we'd like to really appreciate our participants for staying with us till now as we discuss matters quality, and you've seen the various projects that have been highlighted and how we have been able to do that practically. So we'd like now to come to our final round of our final round. So we'd ask our presenters if you'd give us your final comments in regards to QI as we wrap up the session. We'll start with your Faith Chicati.
So with quality improvement, keep an open mind. Always endeavor to try until you see your improvement bear fruits. The other thing would be teamwork makes the dream work. As Lillian alluded yesterday, most quality improvement projects are productive if the team is multidisciplinary, because you have multiple points of view. So yes, teamwork makes the dream work. Keep trying.
Thank you for that. A lot of teamwork is needed. Mary, you can give us your final comments too.
Wish to say is that there's no enough of quality, and whatever service you give is about quality. The outcomes you want is about quality. Quality is there for us to embrace and for us to keep improving. And for us to improve, everyone is very important. However least, however big, everyone is important to quality, and it must be clear to everyone so that we can get our last achievement, the one that we want, improve the service and better patient outcome. Thank you.
Thank you for that. Dr. Wayengo, you can also give us your last comments.
What I would conclude with is to say that there's always something that we can do to improve the situation that we might find ourselves in. So for example, there's always something you can do without waiting for, for bigger things to come. So start small and grow whatever you want to improve. We should not expect, we'll start something today and by tomorrow everything is working fine. So we should be ready to learn from the mistakes and improve until we get to where we want to end up. Those would be my conclusions. Dr. Karingo.
Thank you very much. We'd also like to thank Dr. Nthumba. He has had to step out for another commitment, but he gave us really an elaborate background of the surgical site infections, and we do appreciate that. We do appreciate our panelists for joining us and for giving us those presentations and for the initiatives that we have been able to practically see on how QI can be done from the ground. You've been able to see practically how it is done. So we do really appreciate that. For our participants, thank you for staying with us. For the presentations, they'll be uploaded in the KNH website. The recording will be uploaded in the KNH website. Whichever presentations that we receive and are able to share, we'll see how best to do that. So you can send an email to knhresearch@gmail.com. And with that, we'd like to come to an end. We do appreciate the quality improvement team that has been running these sessions, and that they have also the physical workshop showing the QI projects here at KNH grounds. The team has been led by Chelimo Agneta, who has done a very instrumental work in bringing this together. And we do appreciate the Director of Healthcare Quality, Dr. Okutoi, who has been heading and spearheading the strategic aspects of this work, and we really do appreciate that team. So to all of you, thank you. Let's meet again on Friday. We have a topic. We have the topic that's projected on blood transfusion, and we're going to continue passing on knowledge and learning from each other. Prof. Adam, thank you so much for your comments and for joining us. Thank you all. I'm Dr. Karingo from KNH Research. Have a lovely evening.